This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I'm a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Terminal Ventilator Weaning, Evidence-Based Practice. Upon completion of this AARC webcast, participants will be able to understand the evidence of ethical considerations, understand the statistics of terminal weaning, and understand the procedures for terminally weaning patients. I am pleased to welcome Lorraine Bertuola. Ms. Bertuola is the Director of Clinical Services Respiratory Care at Genesis Rehab Services and is the current AARC Long-Term Care Section Chair. Neither Lorraine nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Lorraine, welcome to the program.
Thank you, Shauna. So I want to start off by talking about the statistics of ventilator withdrawal. 69% of patients are successfully weaned from the ventilator. That's all patients that are ventilator dependent. 23% of those patients died as a result of withdrawal of life support. The median survival rate post-ventilator withdrawal in a study was 0.83 hours. We'll talk a little bit more about that as we go along. In one study of 21 patients, 57% of patients experienced symptoms post-withdrawal of life support. And again, we'll talk a little bit more about that when we talk about protocols. So first I want to talk about the ethical considerations, because I think a lot of therapists have some difficulty with euthanasia and withdrawal of the ventilator, and that they're quite different. So I wanted to make that define euthanasia and the difference between withdrawing ventilator support. So euthanasia is the intentional ending of the life of a person suffering from an incurable or terminal illness. It's the act that ends the person's life, not the patient's condition, versus withdrawal of the ventilator is not euthanasia because it is the patient's condition, not the action of withdrawing the ventilator treatment that causes death. So other ethical considerations. Sedation. I think that's another area of contention for some therapists about sedation. But sedation in the process of withdrawing the ventilator is not given in doses to hasten death. In fact, in a study, it was actually shown to extend the life of the patient. The principle of double effect states that it is acceptable for medications to be used that may have the potential to hasten death in a setting of terminal illness, provided the purpose of the medication is to relieve suffering. And I think that's really important that we always have that in consideration, that the patient's not suffering through this process. So we'll skip to the decision-making process. Once it has been decided that further aggressive medical care is incapable of meeting the desired goal for a patient, discussing ventilator withdrawal to allow death is appropriate. And I really wanted to focus on the fact that this is no longer meeting the patient's goals. And that's really the important part of the decision-making process. So communication is necessary to all members of the healthcare team about the decision and to gain the input on the care plan. It's important at this time to really focus on the comfort of the healthcare provider in this process, because some therapists and some clinicians may opt out of this process. So part of the decision-making process is to schedule a family conference. Once it's been determined that, this is no longer a treatment that meets the goals of the patient, it's time to have a family conference and include, if it's a possibility, include the patient, the family members, and members of the healthcare team, and clergy if it's, something the family wants, clergy to be involved. It doesn't always happen that the family wants clergy involved, but it's important to have clergy involved when the family requests it. So I wanted to talk a little bit about the physician's duty when it comes to educating the patient and the family. So a physician's duty is to ensure that patient family is fully informed for them to be autonomous in their decision. And their information should include risks, benefits, and alternatives to intervention so that the families and patients can weigh out all their alternatives and feel like they're making an informed decision. So the decision to withdraw the ventilator. Well, communication, I can't say enough, communication to everyone that's involved to make the process comfortable for all involved. Educate the patient and family about how interventions are going to be withdrawn. It's just important to say these things are going to be withdrawn and have that discussion so that everyone's comfortable with that. Inform the patient and family that the team will make the patient comfortable throughout the process. I think that, we need to take the worries away from the patient and from the family. Inform the family and the patient of expected length of survival. 50% die within an hour. 90% die within 24 hours, but it could take days or weeks, and sometimes in some cases years. I think we're a little better today at projecting that out and, when a patient could wean versus when the ventilator needs to be withdrawn. And that the continuation of care by the clinical team, that the care doesn't end at the point that we withdraw the ventilator, that the care continues until the process is finished. So I want to move on to talk about some cultural considerations. I think cultural diversity training is recommended. I recommend it as well in the healthcare setting. It's just so important that we understand the cultures and of the patients we deal with. Consideration must be given to understanding the patient and the family as individuals. Although some of these things apply, they may not always be applicable to every person. So patient autonomy is stressed in American and European cultures. Hispanic and Korean cultures deem decision-making a family responsibility. In Japanese cultures, they may be reluctant to share personal information or feelings about this process. And you can just, again, you can't apply that to every single individual, and it really helps to know the patient and the families on an individual basis. I can tell you, from an experience in my family, even though we're of American culture, that we really deem that as a family-making, decision-making responsibility, that it's just not put on the person, that it's a shared responsibility. So prior to withdrawal of the ventilator, there's a lot of things to consider prior to withdrawing the ventilator. And again, this is really where your team healthcare meetings come into play. And decide this ahead of time before you talk to the family about what treatments you're gonna withdraw and what things you're gonna do for this patient. So first and foremost, you have to discontinue all medications, tests, and treatments not directed toward patient comfort. And there's a lot of things to be considered there. Remove unnecessary lines and tubes. And then, this is extremely important, maintain one IV access site for administration of sedation and analgesics. We need to have that route to, administer these meds so that the patient is comfortable at all times. So then determine the non-invasive monitoring needs. And, I know there's a lot of discussion whether we should continue pulse ox on a patient or not continue it, and, should we, turn off the cardiac monitors, and, that all should be determined well in advance of to the day that you withdraw the ventilator. And then discontinue unnecessary alarms. And again, that's going to be a patient-by-patient basis, and you'll determine, what those are going to be, and the health care team needs to be in agreement about how we're going to withdraw alarms and non-invasive monitoring. So again, prior to withdrawal of the ventilator, assemble equipment and medication necessary for comfort and pain control. I just can't stress this enough. There's a lot of protocols when I was looking at the research about how medications should be given, how much, how often, and really, for me, it came down to, can we make the patient comfortable? And, what do we need to do to make that patient comfortable? And, there's a lot of talk about pain medications, antihistamines, also anti-anxiety medications. So, all those things need to be taken into consideration prior to withdrawing the patient from the ventilator. You need to provide a quiet atmosphere and unlimited visiting for the family. Encourage family to engage in cultural or spiritual practices, and or both. I think that's really important for families to engage in these practices. Ensure that caregivers who are uncomfortable with the process can withdraw from the case. There's just some clinicians and caregivers that are never going to be comfortable with ventilator withdrawal, and we need to know that ahead of time. You don't want to get to the day and all of a sudden somebody's uncomfortable with that, and you're having the discussion when the family has moved past this decision making. So we need to make sure everybody's on the same page and everybody's comfortable with this process. And notify the chaplain. And of course, discontinue the paralytics. So now we get to the procedure for terminal weaning. The evidence is unclear as the best way to terminally wean a patient. The literature seems to show that there are two schools of thought for terminal ventilator weaning. And as I did the research, it was quite clear that there was definitely a deviation between these two practices, and how facilities make a determination of how they're going to do this. I really think that it has to be on a patient-by-patient basis, and I think options are always the best way to go for patients. So the first process is to wean slowly, 30 to 60 minutes or less. This includes weaning the SiO2 to room air, the PEEP to 0, and the ventilator rate to 0. Versus wean quickly. The patient is removed from the ventilator with no weaning of the settings. Basically, they're just disconnected from the ventilator. The patient is extubated in cases where there is an endotracheal tube present, as it supports patient comfort. I would strongly consider this in a conscious patient, provided that there aren't any issues with stridor or secretions, or that there's a potential for that. I think that it should be considered in a conscious patient, because then this will allow for verbal communication. And then also to place humidified air to prevent drying of the airways. In the case where you have a trach tube, you have to determine whether you want to decannulate this patient or use speaking valves or, cuff deflation. You really are going to have to, again, figure this out ahead of time with the input of the healthcare team. I think that really puts everybody at ease, knowing ahead of time what we're going to do. And again, that goes back to, communicating with the family about what interventions are going to be removed and withdrawn. So the procedure: the attending physician, social worker, and chaplain, if requested, are encouraged to be present. I think that what I had seen from the literature is that there seemed to be a higher family satisfaction when the attending physician was present, and social worker and the chaplain. But really the evidence showed when the attending physician was present that really supported the family, and they felt good about that. And this is another question to ask. Does the family want to be present during the weaning and extubation? So as you wean down the ventilator, as you remove the endotracheal tube or trach tube, does the family, what is their comfort level with that? Some families are going to be comfortable with that. Some are going to have difficulty with the suction procedure and, some coughing and gagging that might go on when you remove the endotracheal tube. So you need to determine that ahead of time. And then, of course, raise the head of the bed if possible for patient comfort. Clear the airways of secretions, suction the endotracheal tube or trach tube in the mouth. And then administer and maintain appropriate levels of sedation and analgesics for signs of dyspnea and distress. I can tell you that in one of my times providing a terminal wean to a patient, I was instructed to go in and remove the patient from the ventilator and extubate, do the quick wean. And the patient went into distress, and the family was present, and it was a very uncomfortable situation for them, and they expressed that some sadness around the patient being in distress, and second guess their decision to remove the patient. So I think it's just for me, this is the most important part of, besides the communication, that we keep the patient comfortable in this whole process. So documentation. Some of the studies showed that there was when they went back and looked at the medical records for patients that had been terminally weaned, there was a lack of documentation on a lot of these levels. So in order for DNR on the medical record, the decision to withdraw life support, you need to document that in the patient's chart, whether you're doing that on a progress note or, of course, the DNR and the removal of the ventilator. It needs to be documented in the chart. And you need to document the withdrawal of the treatments. Determine what treatments are going to be withdrawn and get the orders on the chart or, in a summary of how the treatments and what treatments are going to be withdrawn. The rationale for the decision. Again, it needs to be documented that this treatment is no longer meeting the patient's goals, and that the decision was made and who the decision makers were in the process, and the conversations that were held and the times they were held. It's just extremely important to document this whole process and the continuum of this process. The process of withdrawal of the ventilator we just talked about, is it going to be a slow wean or is it going to be a fast wean? Is there going to be an extubation or decannulation or, or other methods going to be applied to that patient? The care delivered after withdrawal of life support, there was a big deficit there. So now you've made this decision, you've taken the patient through the process, and then what care was delivered after the withdrawal of life support? And then again, the pharmacological interventions. The person delivering the sedation needs to know at what intervals this patient and, at what doses the medication is going to be provided. So I want to shift and talk about the views of respiratory therapists. In 2003, a survey was conducted of respiratory therapists in California. And, as I came in and looked at the research, there was very little about the views of the therapists, but so happy to find this survey on the ARC site. And they surveyed therapists out in California, and 119 therapists responded to the survey with their attitudes and concerns regarding terminal extubation. So I thought this was very interesting. 96% of therapists had withdrawn life support at least once. And I thought that was a really large number. I was very surprised by that. And although that's been my experience in my practice, I hadn't really thought about how many therapists were out there and actually had withdrawn life support. And I found the next case, or question answer, very interesting as well. on average, therapists reported terminally weaning patients 33 times. Now, and I thought back in my practice, how many times have I terminally weaned patients? And I really couldn't remember because it's been, a lot of years, and I was thinking back over the years, and I'm not sure that it was 33, but it's probably pretty close. So 56% of therapists reported that written orders were not always sufficient. And I want to go back to thinking about the protocols and having standardized protocols for weaning, because I think that's really important, and it goes back to the communication of the healthcare team, and how are we going to do this? Because if we're not in the know about how the wean should proceed, then it certainly hasn't been communicated to the family and what's going to be withdrawn and how it was going to be withdrawn. I think you really need a systematic approach to providing this type of support to patients. 72% of therapists expressed a desire for standardized protocols for orders or orders for terminal extubation. They wanted a protocol either way, standardized or orders that were standard. And in determining extubation, again, they want to know how they're going to provide this this terminal weaning. Is it going to be an extubation? Because really, you need to first say, what are you going to do with the ventilator, and then what are you going to do with the tube, whether you're going to decannulate or extubate. 9% of professionals, I found this very interesting, sought professional counseling following participation in terminal extubation. And also in this study was that many therapists, the majority of therapists, knew where to find counseling, either within the center or externally. So I myself sought some professional counseling after doing a couple of these terminal extubations. I'm really trying to balance out my personal feelings with what I was doing professionally. And I spoke to a minister and really was able to put it into perspective, because it really isn't about my feelings. It's about what we're doing for the patient and for the patient's family. And it's really, I look at it as a gift that you give someone, because we're not in the decision making. It's the patient or the family that's making the decision, and not the clinicians in this case. And so it really became, what do I do professionally to support the patient and their family through this process? And so I was able to, it really helped me come to terms with, how I support the patient and the family members. And then I found this statistic kind of disheartening as a therapist, that 73% of therapists were rarely or never present at discussions leading up to the withdrawal of life support. And I found it disheartening because I feel like as a therapist, I have a lot to contribute to the care plan of the patient. Who knows the patient from a ventilator perspective better than the respiratory therapist? I mean, we know if the patient's assisting on the ventilator, or they're just, what the vent settings are, and, should it be a slower wean? Should it be can we disconnect the patient? Because, it really is going to determine how you're going to withdraw the ventilator for this patient. So, it's really important that the therapist is part of the discussions leading up to the withdrawal of life support. So I wanted to talk a little bit more about this, this patient that I had where we did a quick wean. A lot of these things, as far as having protocols set up ahead of time, determining how the patient was going to be weaned, and being, as a therapist, being involved with this patient, and through the, setting up protocols. None of that was done, and it was years ago. And then, it was probably a reason I sought counseling is because when I removed this patient from the ventilator and they started having distress, and I had to go, the nurse was at the nurse's station, I had to go get the nurse to provide the sedation for the patient, and the family's there, and it's a bad feeling when everything isn't aligned the way it should be for the patient and for the family, and and then having the discussion with the family afterwards, and them second guessing their decision to go through this process was really disheartening as a clinician, and it got me really thinking about what we could have done better, and what needed to be in place to have done this and had a better outcome for the patient and for the family. So, I really want people to think about this and to really think about, some institutions don't do a lot of this terminal weaning, and it doesn't come up very often, but and that's more reason to have these protocols in place and to have, guidelines to help the healthcare providers manage through this process, that that you have a good outcome with the patient and a good outcome with the family. And I think I ran a little bit early, so I apologize for that.
Hi, Lorraine. Hey, not a problem. As a matter of fact, I have a couple of personal stories that I'd like to bounce off of you and get a little bit of your perspective. And maybe this will help some of the people who are listening as well. When I was a new practitioner, oh my goodness, a very long time ago, very, very long time ago. We won't say how long. When I was a new practitioner, in my first job, I was working at a very large children's facility, and my first pediatric death occurred at with a very critically ill patient, and the family had made the decision that this was the time to withdraw the ventilator and to do the terminal extubation. And I remember going through the motions and doing the procedure, removing the endotracheal tube, the child passing at a very short period of time later, very, very quickly, as a matter of fact, after we withdrew the tube, but then feeling very conflicted. And as a new graduate, I wonder whether or not I was adequately prepared for that procedure. Do you have advice on how we can help either respiratory therapy students or new graduates in this given in our profession, in knowing that this is a likely consequence of what we'll be doing for our patients?
Well, I think that definitely having a set standards and protocols in place help guide the whole team. But on an individual basis, personally, and having that experience also fairly early into my career, having to do this and being in my early 20s, I think that having a mentor and having someone to help guide me through this process would have been so beneficial. And we as therapists all talk quite a bit about what our day is like and some of the challenges and some of our more challenging patients or cases. And I think that having a more seasoned therapist to speak to and to guide me through this process, more or less holding my hand the first time, would have been extremely helpful in in making this a more comfortable process for me and for the for everyone involved, I think.
I agree. I wondered if in retrospect, if I would have had someone there to help me, and I don't mean to imply that there were no seasoned therapists with me, but it's a very trying process. Another question or scenario that I had thought about while you were talking about the differences early on in the presentation was about different cultures and different worldviews. We all have our own backgrounds, and even within the United States, we have so many different cultures represented, even from different differences in regions, the north versus the south, east, west, that kind of thing. The different cultures are, again, something that may or may not be easy to adapt. I remember coming from my very specific worldview into a very ethnic area that I had not grown up with, so that it was all new to me. A Hispanic gentleman was passing away. He was on a mechanical ventilator. We had not yet talked to the family about withdrawing ventilator support for him. But as part of the culture that family subscribed to, they wanted to light candles in the room, which is of course very difficult with a patient on a mechanical ventilator with pressurized medical grade oxygen in the room. So do you have any tips for us on how we can, as respiratory therapists, guide ourselves and learn more about our patients and their cultures and be culturally sensitive while also being safe in our practices?
Yeah, well, thank goodness for electric candles today, right? I think that, again, that's where the diversity training, I know I've gotten a lot of diversity training through my college years, but I think that, you know, we as clinicians should always be staying in touch, and as you know, sometimes our careers take us into cultures that we're not familiar with. I think that it's important that we familiarize ourselves with those cultures and, you know, really study up on that. And, you know, there's a lot of information in healthcare and cultures and cultural diversity. There's been a lot of information written about that, and it's pretty accessible and online these days. So I think that, you know, or requesting someone at the hospital or at the medical facility that you're working in to refresh everybody on cultural diversity for specific to your area.
Great. Well, I've been reminiscing, and you've been helping me work through these. We've had several questions pop up, so I'm going to start reading some of those. One of the questions revolves around oxygen therapy during that terminal withdrawal of support. If the patient is alert when you remove the endotracheal tube, is it necessary for us to give oxygen to these patients? You know, how much does, you know, the comfort of having the oxygen versus the comfort of the device weighing into this, if at all?
Well, in the one scenario, they recommended weaning down to, some scenarios had patients wean down to 30%, and most of the scenarios wean down to room air. But again, I always go back to what is most comfortable for the patient. Is the device uncomfortable, or is it the lack of oxygen uncomfortable? I think you have to weigh that out as a healthcare team and really, again, take that by a patient-by-patient basis to determine what the needs of the patient's going to be.
So following up with this comfort measures perspective, could I ask you to give us a little bit of a deeper view of what does comfort measures only really mean for us? When that order is in the chart, do we stop everything? Do we continue some things but not others? What does it mean for a patient to have only comfort measures?
Well, I think that you have to look at the treatments the patient's currently on, and then, you know, one by one go through and determine what's a comfort measure and what's not. Because sometimes treatments can be a comfort measure. For instance, wound care. You know, having a wound care done may be quite painful to a patient, where other times changing a dressing is more about the patient's comfort and cleanliness for the patient and dignity for the patient. So I would think that you would have to look at that and say, you know, is this providing comfort, or is this now providing, is a source of pain for the patient or discomfort for the patient? And then weigh that out and, you know, determine, is this something we're going to do or we're not going to do? And, that goes on to, tube feedings. And, if the patient's, you're tube feeding a patient and they're having aspiration, you really need to talk about, is this beneficial? Is it about patient comfort? And really weigh that out. So there's a lot of treatments. I mean, there's the monitoring, and do you want to monitor oxygen? As therapists, we always think about, well, let's put the pulse ox on them. Well, that's not always going to bring the patient comfort. If they're watching their saturations dropping and the family's watching, it just might not be a comfortable situation. And again, that has to be by a patient basis. And also the level of consciousness of the patient and their condition. If you have a patient with brainstem function only, you may not even provide sedation because, their pain centers aren't there. And so you have to determine whether, the level of the consciousness and, the brain function that's there or not there as to, the process that you're going to follow as far as, medications and the terminal weaning process that you're going to use. I mean, generally those patients aren't weaned down because they're not going to have an issue with distress or pain. So, you weigh that out, and that's where I was saying that you have to look at these procedures and really determine what's best for this individual patient and then move forward with that process.
So the person who had posed this question was specifically asking about suctioning, and I can see where the suctioning could be an either or. If, for example, our patient has been ordered on these comfort measures only, and we've been requested frequently to suction a patient who has copious secretions, I guess at what level is refusing the request beneficial to, more beneficial than acquiescing and suctioning the patient, though it causes them pain? I don't know if there's an answer to that.
Well, I would think that you would look at the patient and say, is this, are the secretions causing the patient discomfort? I mean, when you get down and, also educating the family on this, if the patient is coughing and having difficulty breathing because of the secretions, then that to me would be a time that you'd want to suction a patient. But a patient really that may have some secretions that isn't having difficulty with secretions, I would say, leave it alone. Let the patient be. And, so again, that really has to be talked about ahead of time. Or, if you have a nurse that's constantly calling you into the room every 10 minutes to suction a patient, that's disturbing to the patient, to the family, and the patient isn't benefiting from that necessarily. So I would have to really look at the situation and determine if that's appropriate or not.
Thank you very much. I'm reading the comments. We've had some fantastic comments and information here. So I'm trying to move along with this. One of the questions came in about counseling. You had mentioned that counseling had helped, and then we see on this slide where 9% of those studied in California sought professional counseling. Was it a hospital-provided counselor that you worked with? I'm going to assume, it might be incorrect, that was the kind of counseling that we have listed here on the on the slide in the study.
Yeah, I think that from what I gathered from this information, that it was counseling provided by the hospital. In my case, it was outside of the hospital that I sought counseling, and really just had a good relationship with my minister at the time, and just felt comfortable speaking to him about this subject. So it really, I think, goes to the what you're comfortable with as a therapist. And I think that 30 years ago when I went to school. There wasn't a lot of information about this subject, and I still think today that the topic isn't spoken about very often. But I think and I think that the education that we receive as therapists today is probably a lot better in this talking about terminal withdrawal and your feelings about it, and where we should be as therapists in this whole process. But I think it depends where you went to school and where you can be at from an emotional standpoint in your career with this.
One of the commenters here posted about his experience as a student when his father was terminally weaned, and he has remarked on our board about when he re-entered the room, the ventilator had been removed, but the circuit had been in the trash. So I think that this highlights that the small things can help in this situation, not only with the patient, but the family, who of course has to have the visual of that room. It was an interesting little reminder for the respiratory therapist to, to not take the small things for granted. Do you have any other tips that the respiratory therapist can do, in addition to, of course, this exceptionally important concept of the terminal extubation itself, but small things that might make this easier on the patient and family?
Well, that's a very good point. Not one that I had thought about for a long time, but I think that clearing the space and recognizing that the family is going to occupy the room and what that looks like for the family. But also, I think way back when I was doing this, we used tape to tie the ET tube, to secure the ET tube, and sometimes that would leave a residue on the face. It was really important to me not to have any residue from the tape or secretions left on the patient. Whether it's a decannulation and having the gauze cover the stoma, or what's on the face as far as secretions and making sure there wasn't tape left on the patient, so that the family could see the patient as normal as they could see the patient be. And I think it's definitely the little things. Clearing space, removing the ventilator makes more space for the family. Having comfortable chairs in the room, opening up visiting hours for the family. We talked a little bit about that, that there's not a limitation on how many people can be in the room and, how many people can be at the bedside. So, and at what times, I see, sometimes the ICU limits how many people can be in the room, or, and I think keeping the door closed while the family's visiting is important too, that they have one-on-one time with their family member.
Those are great points, and I'm going to ask you another question here in a second, Lorraine, but I kind of want the audience participation in this while I ask you the questions, so we can give them some time. In the audience, there's a check mark box right above the participant names. Click the box yes or no when you respond to this question. How many people out there are aware of a palliative care committee at their institution? Click yes if you know, no, yes or no. And so, Lorraine, what I'll ask you is, to what extent, to your knowledge, are respiratory therapists involved in these pre-conversations? A lot of the comments on our board today have been, these are great pieces of information to have before we have to go through this terminal extubation, rather than at the bedside, spur of the moment. What are your thoughts on the respiratory therapist role in the palliative care committee?
Oh, I think that they, hold a key role in the palliative care committee. From haven't been involved in a palliative care committee at our company, it's extremely important that they have the view of the respiratory therapist, because, as we were going through this committee, we were having a lot of conversations about, what should we do with the ventilator and how should we wean? And, a lot of physicians, contacted counterparts that work in the hospital. Well, we're in the long-term care environment, and we don't have near the capability of monitoring patients and in the way that you may be able to do in the hospital. And we talked a lot about, what should the procedure be? And, should we leave it open to having both procedures, as far as a quick wean and a slower weaning process? And a lot of the physicians on the acute care side felt like just wean them off and don't delay the process any more than you have to. And, of course, I'm going from experience about maybe we should wean them a little bit slower so that we can manage the dyspnea and the anxiety and the pain through this process. And so I think that, and that comes, like I said, with a lot of years of experience. And, no one knows the ventilator like a respiratory therapist. And, having that input into this process, I may not be an expert in the medication protocol, but I definitely am an expert in how a patient should be terminally weaned. And I think therapists need that voice on the committee. So I think it's important that we involve ourselves as therapists and step up in this process and say, I want to be involved. And I think it's important that we are involved.
Thank you very much. And I see our poll here shows 120 of our participants know of their facilities that they have a palliative care committee, and 54 say that they know that they do not have a committee. So I'm going to clear those responses. I have one more response. So again, yes or no. How many folks out there who participate in these terminal extubations, even after a year, 5 years, 10 years, 20, 30 years of experience, still feel uncomfortable with this actual practice of respiratory care, this aspect of your job? And Lorraine, as we go answer this question, I'm going to flip through into some of your references in case the folks want to take a peek at those. And so Lorraine, I'll ask you as well. And at this juncture of your career, are you still feeling uneasy about this particular procedure?
No, I feel like that it's a gift that we give to our families. Sorry about that. That our family members, it's a gift to the families. We're not involved in the decision-making process, so that really isn't, a part of what we do as therapists, making that decision. We've determined that the patient's not weanable from the ventilator, whether it's your spontaneous breathing trials that you do every day, or, different methods that you've tried to wean and have been unsuccessful. And it really is it's a quality of life issue for the person, and no one can determine quality of life for someone else. It's a very individual thing. And so I have a good comfort level with providing this for someone who has made such a difficult decision, because these decisions don't come easy ever to a family or to a patient. And so, you've spent the team has spent the time educating the patient and the family and giving alternatives. And I think by the point that this decision is made, that it now is something that we give to a patient and carry out the treatment plan. So I feel very comfortable with this process now, and don't have any qualms about removing someone from the ventilator. I don't think that it's a happy experience, but it's something that you're going to give someone that's definitely weighed heavily for that person.
Lorraine, thank you very much.
I'd like to Yeah, I'd like to ask the group one more question, and how many therapists, clinicians out there would like to be involved in the decision, in being involved with how the patients are going to be weaned and having input into the care plan?
That number is growing exponentially.
Yeah.
That's fantastic.
Yeah. Yeah, because, I really encourage, the therapists to be involved because, again, who knows the ventilator like we do as respiratory therapists? We're the expert in the ventilator and the care of the patient and how the patient has responded to or not responded to the ventilator as a treatment. And so I really encourage people to stand up and have their voice heard in the input of the treatment plan at least.
Thank you very much, and I couldn't agree more. In case the folks in the audience don't know this already, the AARC, I think it was about a month ago, opened a new roundtable. Those are free communities on AARC Connect. That is a palliative care roundtable. So if you have an interest in that, please join us on that roundtable. We have some great conversations about topics such as these. Lorraine, thank you so much for joining us today. We have learned a great deal about this information, about this topic, and we appreciate all of the references that you shared with us. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRC e-contact hour. If you are watching this program as an archive, this concludes our presentation.